What will I gain from this video? After watching this video, you will know how to identify common mediastinal abnormalities. The radiological mediastinum is abnormal when the grayscale image of the mediastinum is too white or too black, the size or shape of the mediastinum is altered, or the position of the mediastinum is shifted. What causes the mediastinum to be too white? Well, most of the pathology we encounter within the mediastinum causes the mediastinum to be too white, and this includes tumor, calcification, hiatus hernia, mediastinal lipomatosis. In this example, we have a large mass within the mediastinum. The mediastinal location can be confirmed on the lateral X-ray. The mass is causing the mediastinum to be too white, and in fact, it's making it very difficult to clearly identify the trachea or the main stem bronchi. What causes the mediastinum to be too black? Air and hiatus hernia. On this example, we can see some linear black streaky areas within the lower neck, as well as adjacent to the aortic arch and descending aorta. On the lateral, we can see some streaky linear densities within the anterior mediastinum. This is an example of pneumomediastinum, and this should not be mistaken for pneumothorax. What changes the size and or shape of the mediastinum? Tumor, adenopathy, goiter, aneurysm, unfolded or ectatic aorta. Here we have an abnormal contour to the lower mediastinum. Instead of identifying a normal right heart border, we see the edge of a large mediastinal mass that is containing air. This represents a large hiatus hernia. The hiatus hernia is clearly seen within the inferior middle mediastinum on the lateral X-ray. Previous surgery is a common cause of change in position of the mediastinum. This patient had a previous right pneumonectomy. Because of the postoperative changes within the right hemithorax and compensatory hyperinflation of the left lung, the mediastinal structures are shifted to the right. Shift of the mediastinum can also be seen with tension pneumothorax as well as with large pleural effusions. Here we can identify a large mass that changes the contour of the mediastinum on the right and on the left side. On the lateral X-ray, we can confirm that the mass lies within the anterior mediastinum and is displacing the trachea mildly posteriorly. We can confirm that the mass lies within the anterior mediastinum because we can clearly see the aortic arch and descending aorta, which would not be visible if the mass was abutting the aorta within the middle mediastinum. In this case, we see a large superior mediastinal mass. The mass is displacing and narrowing the trachea. We can confirm that the mass lies within the anterior mediastinum by its location on the lateral X-ray. Here we have an abnormal contour of the heart on the right side and an abnormal contour of the superior mediastinum on the left. We can confirm that the abnormality lies within the anterior mediastinum on the lateral projection. So when we can identify a mass within the anterior mediastinum, we should be thinking of the 5 T's. Think of thyroid, thyroid goiter or thyroid tumor. Think of thymoma, teratoma, testicular carcinoma metastases, and think of terrible lymphoma. Also consider the possibility of aneurysm of the ascending aorta or mediastinal lipomatosis. Here we can identify an additional edge within the mediastinum on the right side, centrally. On the lateral projection, we can identify that there is an opacity that lies within the middle mediastinum. In a similar case, there's a mass within the mid portion of the mediastinum causing an interface that is separate from the right heart border. This is identifiable adjacent to the right hilum within the middle mediastinum. When we identify an abnormality within the middle mediastinum, we think of the anatomical structures. Think of the nodes and possible adenopathy related to sarcoidosis, lymphoma, infection, or metastatic disease. Think of the bronchi, bronchogenic carcinoma or carcinoid. Think of the esophagus, leiomyoma, carcinoma, or hiatus hernia. And think of the aorta, aortic aneurysm or aortic ectasia. Also consider the great vessels, aneurysms of the great vessels, or ectasia of the great vessels. Here is a large mass that occupies a significant portion of the right hemithorax. We cannot identify the medial border clearly on the PA, and we cannot identify the posterior border clearly on the lateral X-ray. This is a mass that is localized to the posterior mediastinum. Now, when we were talking about the anterior mediastinum, we were talking about the 5 T's. When we talked about the middle mediastinum, we talked about the anatomical structures within the middle mediastinum. When we think of the posterior mediastinum, we should be thinking about the nerves. Think about nerve tumors such as neuromas, schwannomas, or ganglioneuromas. In addition, think of the lymph nodes and adenopathy. Think of vascular causes of an abnormality, such as an aortic aneurysm. And also think of paraspinal or spinal abnormalities, such as an abscess or metastatic disease. There are several radiological signs related to the mediastinum. One of note is the 1-2-3 sign, where we have right hilar adenopathy 1, left hilar adenopathy 2, and right paratracheal adenopathy 3. This sign and these findings are felt to be pathognomonic of sarcoidosis. Another sign is the hilar overlay sign. If we have a mass centrally within the thorax, and we can clearly identify on X-ray the pulmonary arterial branches, then the mass must lie either anterior or posterior to the hilum within the mediastinum. The iceberg sign signifies that we are only seeing a portion of an abnormality. If we see the edge of an abnormality within the upper thorax or the lower thorax, and the lower edge of the abnormality is extending laterally and not medially, then we can expect that there is going to be further pathology related to this abnormality, either below the hemidiaphragms if this occurs inferiorly, or in the neck region if this occurs superiorly. If the mass is obscuring the contour of other normally visible mediastinal structures, then it can form the silhouette sign. Here, the mass within the anterior mediastinum is causing loss of the normal left cardiac contour. Hiatus hernia can have various appearances. It can be quite small and not identifiable on X-ray. It can be moderate size, as in this example, and contain air. Or, as in this case, the hiatus hernia can also be large and occupy a significant portion of the hemithorax. Here we see abnormal mediastinal edges caused by a massive hiatus hernia. On the lateral X-ray, we can identify air within the herniated stomach, but also gas within the transverse colon, which is also herniated into the thorax. As a patient ages, the thoracic aorta increases in length, but is stabilized by the intercostal arteries. And this causes the aorta to take on sometimes quite unusual shapes, which I have called the swaying aorta. This is not to be mistaken for aneurysmal dilatation. So in summary, when looking for mediastinal pathology, look for change in grayscale, or too white or too black, change in size and position of the mediastinum, loss of normal edges, lines, or stripes, or additional edges that can be formed by pathology. If you identify an anterior mediastinal mass, think of the 5 T's: thymic lesions, teratoma, thyroid, and testicular cancer metastases. If you identify a middle mediastinal mass, think of the mediastinal anatomy in the middle mediastinum. And if you identify a posterior mediastinal mass, think nerves.